Today, I'm excited to be joined by Dr. Teddie Buchner, an expert in the area of pediatric and maternal mental health related to sensory processing and integration. We'll be diving deeper into this topic, including recent research and actionable takeaways you can implement right away. Welcome to Pediatric Pioneers, a MedBridge podcast where we conquer challenging topics for the pediatric therapist through conversations with pioneers who have blazed new trails in our practice. Our aim is to deliver actionable takeaways for practitioners like you. To receive continuing education credit for this episode and access bonus resources, make sure you check out medbridge.com. Hello, I'm your host, Nicole Quint, and I'm an occupational therapist with over 20 years of experience in practice and academia, specializing in pediatric practice and the improvement of occupational participation and performance through my expertise on executive function, visual perception, social emotional learning, sleep, and sensory processing. It is my passion to support pediatric therapists like you so that you can best serve the families under your care with evidence-based practice solutions, easy to implement advocacy approaches, and new ways to lean into your skills within the challenging pediatric landscape. Welcome, Teddie.
Hi, how are you, Nicole?
I'm great. Thank you for joining us.
Oh, thanks so much for inviting me. I'm really excited to talk about this and share this with your audience.
Yeah, this is an important topic. So could you get us started a little bit by sharing more about yourself and how you are involved with pregnancy-related maternal mental health?
Sure, no problem. Well, I started my occupational therapy career in rural Michigan in community mental health, and I traveled around Allegan County and worked with individuals who either had developmental disabilities or severe and persistent mental illness, or sometimes both. And I mean, I did everything. I was the only OT. So splinting, wheelchair adjustment, environmental modifications, fine motor, visual motor, emotional regulation, whatever. And my clients spanned from the ages of 3 to 94. So it was quite a diverse client base. I decided that I really wanted to focus more on pediatrics and in pediatric mental health specifically. So I got a position at Easter Seals, Michigan, and I worked on an incredible interdisciplinary team there that assessed children who are generally wards of the state. They were either in foster care, the juvenile justice system, residential facilities, or sometimes children who had recently been adopted. And we did comprehensive neurodevelopmental trauma assessments. And that's when I started, because sometimes the biological parents were still involved. And talking to the biological mothers, I started hearing some of their stories about intergenerational trauma, mental illness, substance abuse, domestic violence, those kinds of things. Then I moved to Canada and worked with Sick Kids Hospital in their community mental health program. And I started an independent home based pediatric practice, and I worked at a women's health clinic in Toronto. So, starting back at Easter Seals, when I started to notice some of the commonalities in the mother's stories, I started adding things to my regular assessment. So my regular pediatric assessment, a regular thing I added in was to ask about the mother's mental health during her pregnancy and also that first year postpartum, and also kind of what was going on in her life during that time. And it was really, really kind of staggering how often mothers were reporting mental health challenges during those times.
hmm Did they ever say that anyone else had asked them about this, or were you really the only one diving in?
No, they were kind of surprised because
Mhm.
often too, I would say, because I did a lot of home based. So I would say, oh, Johnny can go and play for a few minutes and come back, kind of get used to the sound of my voice, me just being in the house. And then while the child was out of the room, I would often ask these questions. And they were like, oh, well, what does this have to do with, my son or my daughter and what's going on with them? And I said, well, sometimes I said, we can see certain patterns. I said, it helps me know what to look for. But it was interesting because even if it was like 5 or 10 years later, these mothers were still like, "Oh, let me tell you, about their stories." So they were eager to share.
Right. That brings us to this idea of maternal mental health and how important it is and probably how overlooked it is. And I
Mhm.
think it's a really nice fit for us to be the really the providers who are looking at this because we're spending time with the mothers.
Mhm.
We're understanding their ability of their occupational role as mothers. So,
Mhm.
why do you think that it's important for us to discuss maternal mental health? And what questions should we be asking as occupational therapy providers or other healthcare providers? Is there anything that we should be questioning in this topic?
Oh, absolutely. I mean, as a pediatric therapist, right? You're technically the child is your client, but really that whole family is your client, right? Family-centered care is always the core. And that mother-infant dyad, they're two different people, but you almost have to look at them as kind of a unit sometimes when you look at that developmental picture. So, I mean, here's a few stats which might kind of give you an idea just to kind of frame it in context. So, approximately 80% of new mothers have some form of the baby blues. And I think most of us have heard of the baby blues, right? You've heard of
Mhm.
those. But that's different than kind of a perinatal mental illness or postpartum mental illness. Um, Baby blues, they can be a little bit tough when you're going through them, but the symptoms aren't as intense and they usually dissipate within about 2 weeks, right? There's kind of that 2 week period where you're just not feeling great, your hormones are readjusting, and then not that they're all readjusted after 2 weeks, but you kind of become more emotionally regulated, right? After those couple of weeks. So, 1 in 7 mothers will actually experience serious depression and or anxiety. Sometimes it's both. And then about 1 in 1,000 mothers will experience a postpartum psychosis. So that's actually a lot rarer. And I also think an interesting fact is that 1 in 10 fathers experience some kind of postpartum mental illness, especially if they are
Yeah.
co-parenting within the home with the mothers. In fact, if the mother has a postpartum mental illness, the father's risk of mental illness goes up by 50%. So we need to be looking at the whole family. Yeah.
Right. Wow. So what I'm hearing from you is it's pretty safe to assume that the majority of the mothers that you meet are going to have baby blues, at least, right?
Mhm.
And then B, that we really need to be paying attention for when the baby blues is something else.
Right.
And if it is something else, that it's safe to really kind of say that it's really likely that the father, if he's involved, is potentially experiencing it as well.
Yes, exactly. So then you have this new little baby, and its main support system, or both parents could potentially be struggling with their mental health. So, statistically speaking, we know that a lot less funding is directed towards research regarding women's health, especially women's mental health. So, pregnancy related mental health is just not given the attention that it should.
Mhm.
Women are often referred elsewhere. A lot of times, a woman might say to maybe her primary practitioner that she's struggling with her mental health, and that practitioner may say, "Oh, well, you should really talk to your OBGYN." Woman talks to her OBGYN, they're like, "You should maybe talk to a psychiatrist." Psychiatrist, once you can actually get in and see one, will say, "This is more of an OBGYN." And a lot of women get shuffled around because
Right.
it's just not a specialty for anyone. There's lack of screenings, lack of regular check-ins, there's lack of resources and access. Um, and there's also that stigma, right? That stigma of maybe possibly being labeled not a good mother or not being able to handle what's going on. So a lot of women suffer in silence.
And I know I've heard you say before, there's a fear of being labeled beyond the
Oh, for
stigma.
sure. Right. Right. Sometimes if women go in and they say, "I'm really struggling with my mental health," what people think about right away is that postpartum psychosis, right? That gets sensationalized in the media. Or they go the other way and they say, "Oh, this is normal. Everybody's sad after they have a baby. You'll get over it." That's what women hear a lot.
Mhm.
So on one hand, sometimes there's an over response, and people may take that child and put that woman into like an acute mental health care, and sometimes that's what women need, so that's good, but not always.
Mhm.
Or it just gets dismissed as kind of a regular thing, and you just need to deal with it. And I've had moms say to me, "I thought I was going to feel like this for the rest of my life, and I couldn't imagine what I had done to bring this on." So it's really heartbreaking.
Mhm.
The pain, it's so apparent in women's stories about their time of life, and it's really heartbreaking because they feel so isolated and alone. Um, And here they are, they're the primary caregiver for this new little life. So I think not only is this a critical area of practice for pediatrics, right, in the child's development, but it's also critical for the woman, what she's experiencing in her quality of life.
Right, and then I think there's always that fear too of, am I gonna lose custody?
Yeah,
Are children and
absolutely.
family services gonna get involved? Are they gonna, so the suffering in silence is real, and there's valid reasons for it.
Absolutely.
Beyond, being pinballed around between healthcare providers because nobody specializes in this. So I think it's a real opportunity for occupational therapy providers. We can be that safety net to hear them
Absolutely.
without judgment and provide sound referrals or help, in this process. And I think add to that what I'm hearing from you with all of this is, we forget that this is a huge transition
Huge.
from pregnancy to being a mother,
Yeah.
the postnatal care that's involved, and then if they have a child with a disability,
Mhm.
throw that into the mix. And they're not
Right, that's a
and they're not
completely
sleeping.
different story. That's another
Right.
podcast talking
Right.
about that, or if the mother has disabilities herself,
Right.
right? Those are things to think about. So, yeah, there's this narrative in society, right, that women should just naturally know what to do to be a good mom, and that pregnancy, like we said, in that perinatal period should just be a blissful time, the happiest in a woman's life. Well, when that's not the case, women often feel like failures, right? If they've had a traumatic birth or the birth didn't go the way that they had planned, they kind of feel betrayed by their bodies, right? They couldn't do things the way it should have been done. And then that starts to creep in. Well, if I can't do that, then am I able to be a good mother? Right. And all of that doubt starts to creep in. So I think OTs in pediatric practice, especially those of us who are working in early intervention, we have access to these new mothers, or it could be mothers again, right? Because sometimes
Right.
different pregnancies, different dyads, different mental health challenges. You may have 3 children and only have a postpartum mental illness for one of them, right?
Mm.
I mean, that happens. Um, so some women just there's no screening at all in the US in some places, and in Canada, it's kinda hit and miss. Most often it's just a 6-week OB checkup after the baby's born, and the mothers might get a quick, "How's your mood been?" And that's it. And interestingly, when you talk to other mothers who have this history and have gone through this, they'll say, "Oh, I got a form to fill out with all questions about my mental health, but I wasn't going to tell them what was really going on. So I lied. I knew the right answers they were looking for. I didn't want to talk about it. I was afraid to talk about it. I was uncomfortable talking about whatever. So I totally lied and told everybody everything was fine." So we really have to cultivate these relationships with, again, OT is so good at that, right? Using that therapeutic use of self, making these women feel safe and having them know that this is a safe place to tell you exactly what's going on because I know you're going to listen and I know you're going to validate. So,
Mhm. Right, and I think it's important to we have to always remember that we are grounded in mental health, right? Our
mhm,
profession started there.
absolutely.
That's what makes us different than the other helping professions. We're grounded in mental health, or the different therapies. And I know I've heard you say, we pride ourselves on our holistic consideration of the client in all these different contexts. But we have to make sure that we're communicating that to who we're working with so that they understand that we are the person that can receive this information without judgment and help them. So I think that that's a great point. And yes, the EI therapists out there, you can really dive into this, which is exciting. So,
Right.
what do we need to be looking for?
So you need to kind of, when you're talking to these moms, get to know your client the best you can. And I understand that, in some contexts, you get to spend a lot of time with these families, and in others, it might be a quicker interactions. So, we need to be looking for signs of distress, right? Look at the mother's mood. Um, Eye contact is a cultural thing, so you have to keep that in mind. But also, what's her eye contact like? What's her attitude look like towards the baby? What are her nonverbals telling you? And really start paying attention to some of those things, and ask. Like the most important thing is to just be non-judgmental and validating. I also think some of these women have maybe tried to tell their stories, and people have said, "Oh, it's not that bad. I went through something like that," or "Oh, it's not that bad." A lot of women go through it. So we really need to take these women at face value and listen to their stories. And without bias or our own perspective or our own experiences creeping in, the mother's perception of her mental health and her experience is really the only one that matters.
Hmm. And, there's always these perfect stories and pictures and narratives on social
Oh,
media.
yeah.
And
Oh,
we
yeah.
forget they might even have a team of professionals helping them in the back, right?
Right, right. And I mean, and that's I mean, the more women I talk to and the more women I work with in this field, the more unusual it is for everything to go right,
Mm,
right?
big
Breastfeeding
part.
can be a huge challenge, no skin to skin contact possibly after a birth. Um, just women just not having energy, just, being able to get done what they need to get done. Like, to me, it's more the exception, these perfect kind of stories that we see, and I think we really have to talk about that more because and there's another, phrase out there, mom shaming, right? Where you're just
Right.
not up to stuff, and that's just not the way it is, and I think, as women especially, we really have to reach out and support each other. I mean, Western culture has women dealing with this all on their own, but there are some cultures, in other parts of the world where new mothers are kind of just cocooned in love and support for that first year to just help them, and I think that, we're not meant to do this alone, and I think the more we
Mhm.
can get those stories out there, better.
Yeah, the OTs and OTAs out there, we can be that cocoon. Or if
Mhm.
you're a PT listening to this or a speech therapist, we can all be that cocoon or help them get to OT to have that cocoon,
Absolutely,
right?
absolutely.
So you gave us a little bit of the stats that I think are so important. I think a lot of people these days are hearing some of the staggering numbers of maternal mental health deaths
Mm,
and a lot of really negative types of situations that are going on in healthcare right now in the United States. And I know you've kind of got you have a background in the States, but you've also treating in Canada. So you're seeing two different
mhm.
types of healthcare. Um, so we're hearing some of these numbers. You've given us some numbers on the mental health piece. But what does the recent research say about this topic? And can you give us some of the most important highlights that we can use in practice?
Absolutely. Um, so I think the biggest thing to remember is that the symptoms of maternal mental health and postpartum mental illness are really complex. Like I said earlier, when we hear postpartum mental illness, we tend to either think of postpartum depression, and we have a picture of someone being very sad and weepy, or maybe the psychosis, right? That sensationalized part that we hear about in the media. But the truth is really quite a bit different. So, for example, here are some common symptoms of postpartum mental illness, right? Irritability, sadness, definitely. Anger is a big one. Feeling overwhelmed, exhaustion, nervousness, feeling on edge, difficulty sleeping even when your baby is asleep. And that's something that will give women pause because, yeah, a lot of us, after we have babies, we're irritable, we're feeling overwhelmed, we're exhausted, it's a huge transition, but, we're exhausted. So when that baby is asleep, we can just fall asleep, like, right away, even if it's for half an hour. But for some of these women, their baby is asleep and they are so overwhelmed with, feelings of anxiety that even then when they try to sleep, their brain is racing, their heart rate is up. I talked to one woman once, and she said that even when her baby was sleeping, she felt she had to be watching him.
Mm,
So she would stay up all night sitting in a chair in his room watching him to make sure that he was okay. And she didn't realize that was not typical until she had her second child and didn't have any problems with her mental health and fell into much more of maybe a typical pattern. And that's when she said, "Oh my gosh, I must have had, some kind of anxiety during that time," because she had no other history of mental health. But, lack of appetite,
mm,
feeling out of control, intrusive, scary thoughts that don't go away, feeling insecure about being alone with your baby, or thoughts of harming your baby that are distressing or upsetting to you. And this is a really big one, because women who have thoughts about harming their baby that are distressing, they don't wanna talk about that, right? Because someone is gonna take my baby away. In actuality, if the women are really distressed by these thoughts about harming their babies, I've talked to women who have hidden all the knives in their house. I've talked to women who won't drive because they're afraid that they have fantasies of driving into a telephone pole, so they refuse to drive. These women are not the ones who are likely going to hurt their child because they understand they are distressed by this, they are upset by this. It's when those thoughts aren't distressing, that they're maybe tipping over into a possible psychosis, right? And that is completely different. But these thoughts of harming your baby, that can be very typical part of a postpartum mental illness that they don't talk about. So again, they're carrying this in their hearts and just suffering in silence. And it's really, really sad.
Yeah, so, I mean, I'll be honest, some of this sounds terrifying. So, I mean, they need help. Like, the first
Yeah.
thing I'm thinking of is how terrifying this must be and stressful.
Mhm.
Um, and, they need someone to help them and to talk to. So, I really think I'm really glad we're talking about this because I feel like it's just been kind of hidden under the surface for far too long.
Mhm.
And the research is very clear. We have these things to look for, but what I think is challenging is how do we figure out the spectrum of what is baby blues
Right.
versus what is truly a mental health crisis or a need. And then I know you said the psychosis is really kind of the outlier.
Mhm.
So, where is that sweet spot, if you will, for where we need to say this person is really experiencing pregnancy related mental health issues?
Um, I think it depends on the person as well, right? Because it depends on the intensity of the symptoms. It depends on what their support system's like. It depends on how they're able to cope with what's going on, right? What's their resilience like? What are internal factors within them that are helping with that? So most new mothers will feel some of those symptoms that I just listed, right? Off and on, and experiencing them for a short time, like a couple days of real irritability because you didn't get much sleep, but then it kind of goes away, right? Each woman really needs to be considered individually in her own context, because when there is, like I said, there might be women reporting these different symptoms, but when there is a real postpartum mental illness, the symptoms are more intense and they don't go away. They may be a bit transient with like different symptoms kind of dominating on different days, but the big difference is that debilitating nature of the symptomology and how long those last.
Okay, and that's typical for a lot of things, right? That's
Right.
kind
We
of
need to listen.
our
Yeah, we need to
benchmark
listen.
is the litmus test is how is it really affecting
Mhm.
your ability to do what you need to do to take care of yourself, the
Right.
baby, the people in your family, and how long is it lasting? So, you know, when we're thinking about the research or kind of the evidence here that's supporting all of this, our other concern has to be how does this influence the care on the child and the development of the
Right.
child, right?
Right. So, when I was doing my research, I did quite a deep literature search. And what I found was that the literature kind of characterizes the effect of maternal mental health on pediatric development through three main mechanisms. So, if we look at anatomical and physiological, neurological or brain development, so when these babies are born to mothers with prenatal mental illness, so mothers who have significant depressive or anxiety symptoms, the blood levels of the baby's neurochemicals at birth mimics the mother's. So mothers with depressive symptoms, they will have babies with lower levels of dopamine and serotonin. So the babies are actually depressed. And mothers who have anxiety systems will have babies with higher levels of cortisol and norepinephrine. So think about how that's going to kind of affect that baby's temperament in their first few weeks of life, right? And these chemicals being in the baby's bloodstream will also have some anatomical results. So their brains are going to look a little bit different. So they'll have reduced cortical thickness, decreased white matter volume, decreased connectivity between hemispheres, right? So think about sensory integration and all of the communication that has to go on through that brain, right? There'll
Right.
be lower vagal tones, so much harder to recover from that stress response. They'll have a larger amygdala. And then physiologically, they are going to have a much more sensitive threat response, right? They're going to be much more irritable. They're going to pick up on things much more quickly because that HPA axis is just overdeveloped. And they'll be generally a little bit more irritable, harder to soothe. It can be hard to engage. So, I mean, think about women who are coping with their own mental health challenges, and they have this little baby who's also struggling with some of these challenges.
Yeah. That's tough for sure. I mean, that's pretty profound what you're saying about this kind of first category of what we can look at. And I think it's important for us hearing this to also appreciate you're treating both parties here.
Right, absolutely, right? Because
Mhm.
the brain is plastic, right? We know that as OTs, right? And that it can change and rewire itself. So the things that we also really have to look at from the mother's perspective is how her mental health might be affecting her child is also through her through the baby's attachment patterns. So what we look at is her attachment fostering behaviors. What is she doing that's fostering attachment with this baby? So how she interacts with her child can possibly set up attachment patterns for the child and how they interact later on in life. And then also that engagement in co-occupations, right? Which is very occupational therapist based.
Mhm.
So that give and take. And I look at co-occupations as that engagement of two people or maybe more, but they're engaged in the same activity or the same occupation
Mhm.
at the same time in that same space, right? So we're absolutely, I'm going to hope say this more than, than once during this conversation, but we're not blaming the mother. Okay.
Right.
These women
Right.
are coping with their mental health and trying to take care of this baby the very best they can. But in those typical co-occupations like feeding, changing, snuggling, rocking, right? If they're feeling detached and unable to invest emotionally, that baby is going to pick up that energy and they in turn
Mhm.
will not give the emotional responses back, right, to the mother and it becomes a bit of a cycle.
Well, I hear these 3 categories, right? The anatomical, physiological, neurological development that's influenced, the attachment patterns and the affordances that the mom can provide, and then the engagement and co-occupations. When I hear those 3 categories, my brain automatically says, those there's so many opportunities here for us to jump in and support and
Absolutely.
help. So that's the exciting part.
Yeah.
Right, that's what gets me excited. So, kind of appreciating that you've done this robust literature review, you have done research on this topic, you treat in this realm, I mean, have treated in this realm. Um, what have you found in terms of some of the symptoms, that mothers have really explained to you so that we kind of know what that experience is like for them?
Yeah. So again, like I said, it's really important to remember that the symptoms they're quite complex and they might present differently.
Mhm.
So when I did my research, I did a frequency analysis of the symptoms that the mothers reported. And what I found was that mothers identified feeling overwhelmed as the most frequently reported symptoms. And it was selected by 12. I had 14 participants, so it was selected by 12 of them. And then next commonly was exhaustion, reported by 11 mothers. And then irritability and nervousness, both by 9 mothers. And some of those you're like, yeah, you can kind of see that. But anger and feeling out of control were reported by 6 mothers, right? And that's not something we often associate with a new mom, is that anger and feeling out of control. Lack of appetite by 5 mothers, and having intrusive, scaring thoughts and having thoughts about harming the baby that were upsetting or distressing was reported by 3 out of the 14 mothers who I spoke with. So, it's not that out of the norm. And
Yeah.
then I left a space for mothers to just add on the form other things that I maybe hadn't covered. And one mother listed, she wrote anxious, desperate, and then wrote 3 pluses behind the desperate. And I thought that really talks to that feeling, right? That pain.
Yeah.
And then another wrote increased anxiety in the car when driving her baby, which was something she really felt only when she was in the car. So that was a little bit interesting.
Mhm.
Um, I think what's important here to note is that none of the mothers I talked to reported only one symptom, right? They
Oh.
all reported multiple symptoms. So when I did that frequency analysis, it allowed me to identify pairings of the symptoms as well that seem to go together. And most commonly paired symptoms were exhaustion and feeling overwhelmed with 11 mothers. So that's pretty intense
Yeah.
feelings, right? Feeling overwhelmed was also paired with nervousness by 8 mothers, as was irritability and feeling overwhelmed. So that feeling overwhelmed keeps coming in there.
Mhm.
Um, Irritability and exhaustion and nervousness were also reported 7 times as a pair. And irritability and nervousness were paired by 6 mothers, as were irritability and anger. So again, you're tired, you're feeling irritable, you're angry. Sadness and exhaustion was another one, but it was reported a little bit less. And then irritability, feeling out of control was also reported. So not one mother reported only one symptom, right?
Mhm.
One mother who was involved in my sample reported 12 symptoms, and the fewest that was reported was 4. So these mothers are feeling a huge range of diverse symptoms, and we can't just ask people if their mood is low. If we're looking at,
Right.
because they may say, no, my mood is fine, but they're angry, they're irritable, they're feeling overwhelmed. So we have to be asking the right questions as well.
Right. And are they even tapped into it? Because they might be just so focused on the baby
Absolutely.
as to be expected. So tell us a little bit, I think it's very easy for OTs or anybody else listening to this that works in the pediatric realm of early intervention to know how to jump in and support the child who has developmental concerns or any kind of risks,
Mhm.
right? But that second category you talked about was attachment.
Yes.
So can you differentiate bonding with attachment and how we should be thinking about that for these mothers that we're working with that we want to support?
Yeah, absolutely. So a lot of times you'll hear those words kind of interchanged, right? Bonding and
Mhm.
attachment. But when you look at the literature, bonding is really the strength of the relationship from the mother's perspective. And that's why you hear about prenatal bonding. She may be bonding with her child before that child's even born. And for mothers who have good mental health, that's usually what happens. Sometimes anxiety, depression, psychosis can get in the way of that bonding, which really kind of disrupts that whole pregnancy, experience for the woman. Now, attachment is the strength of the relationship from the infant's perspective. So the infant, I'm not gonna go too deep into attachment theory, but it's a bit out of scope for this conversation, but it's important to understand that the attachment patterns that a child learns, whether it's a secure attachment or an avoidant attachment or an
Mhm.
disorganized attachment, is often those foundations are laid in the first year of life, and it generally remains stable through adulthood. So it will have some of those lifelong repercussions on social interactions and how they handle relationships.
Mhm.
What we really need to look at is if the baby's emotional and physical needs are being met consistently. And if they're not being met consistently, even if the physical needs are being met, but those emotional needs aren't being met, then the baby can develop those atypical attachment patterns that I talked about.
Mhm.
Right. And then, like we said, this is so complicated because like you were talking about some of the stigma and the concerns and the self-blaming and the mother shaming, there's a lot of context here that I think is pretty intense to
Yeah.
consider,
Yeah.
right? So then, we're going in, we're talking about that attachment piece that I think is really important. Some of these moms that we're concerned about, their ability to care for the child, what it happens when they're only really maybe addressing the physical needs of the child and not addressing the emotional piece.
Right, exactly. So, for some of these mothers, those concrete tasks, right? I know how to change a diaper. I know how to
Mhm.
get the child dressed. Feeding can be a bit, it depends if they're breastfeeding or bottle feeding or a bit of both,
Mhm.
because breastfeeding can add a completely other dimension to that in their mental health. But, feeding, all these things that they know they have to do, they can kind of check off the list, right? And handle those physical needs. But if they're not engaging with that baby, so think about what that engagement looks like, right? Are we singing when we're holding the baby? Are we snuggling the baby? Are we giving them little kisses? Are we, rubbing their back and, just engaging with that child, lots of eye contact and smiling, right? If the mother is not able to handle those emotional aspects of it because she's dealing with her own mental health, again, I'm not saying these mothers are doing a bad job. I'm not saying
Right. We're
it's the
not
mother's
blaming.
fault, and I think that's so important, we have to stress that,
Mhm.
right? They are doing the
Right.
very best they can. But if that emotional aspect is missing because it's just not possible with the mental health challenges she has, that baby starts to attune to that, right? Babies
Right.
look to their caregivers or to their mothers, since we're talking about mothers, for their own emotional regulation and their own cues as how to
Mhm.
respond. So if they see more of a blank face or someone who's not looking at them, they begin to disengage. And
Mhm.
then what happens is the mother is trying to engage with her baby, but the baby is not engaged because they've learned these patterns already. And they take the blame on themselves. The mother takes that blame on themselves. I'm a bad mother. And then kind of disengages further. And then the baby disengages further. And we have this cycle that goes on, right? Where that neither one of them is getting what they need emotionally from those co-occupations.
Right, and we're not blaming the mother. I can't stress
Oh,
that enough.
absolutely not. I know,
Got
I was
it.
gonna say I'm gonna say this so many times because when we're talking about this, it's like, ooh, all the onus seems to be on the mother to do these things right,
Sure.
but we're not, right? They see there's a woman who needs support.
Right, and but I'm thinking about it from it makes sense. What do we always say? You can't take care of someone else if you're not taking care of yourself.
Right,
So
right.
I think that that's it's all just putting it all into context. But what I'm hearing from you about these co-occupations that are also part of the role of being a mother or new mother,
Mhm.
they have a very rich sensory component to them.
Very. Yeah,
Rocking, touching,
yeah,
snuggling, skin to skin, everything that I'm hearing, and feeding, all of these things, diaper change, have these intense sensory components because everything is rich to a child that's been swimming around for a while and is now
right, it's all
playing with
new, yeah.
gravity and a whole different world. So, and I know you looked at the sensory piece in your research as well.
Yeah. So, in my research, I focus specifically on vestibular and proprioceptive systems because they are, well, and tactile, because they are those foundational systems, right? When you think about Ayer's theory, those foundational primary systems that kind of come online first, right? And then everything else is sort of built on top of that and develops a little bit later. So, again, what is rocking? Right? We're giving, yes, and I am rocking, but we're giving that vestibular input, right? When we're swaddling or when we're holding that child tight and rubbing their back, we're giving that proprioceptive input. We're helping them map, right? Their body, right? And so even if we take the emotion out of it, which I mean you can't really, but we just focus on the sensory, right? If they're wet, if they've got a poopy diaper and they're crying because it doesn't feel good and this person comes and she picks them up and rocks them and she cleans them and she puts and now I feel good and I feel dry and I feel safe, right? It's associated with that sensory feeling. The same with if I'm hungry and now this person comes and I'm fed and now I feel satiated and I feel good and I feel safe, right? Like it's all wrapped up in together, right? And
Mhm.
so the reason I focus on that proprioceptive and vestibular is for one, because those are the primary sensory systems, sorry, that develop. So I'm looking at, right, that early development. But also, I mean, as a pediatric OT, what do we hear all the time? Right? That this child can't sit still, child can't focus, this child, I have kids coming to me and the mothers are telling me or the parents are telling me, "Oh, they have ADHD. We're pretty sure they have ADHD. They're
Mhm.
on medication. They're on the highest dose and it's not doing anything." And I'm like, "Ooh, not that I'm a doctor, but maybe it's not ADHD, right?"
Right.
Especially kids who haven't had intensive psychoed testing, right? Maybe it's
Uh-huh.
not ADHD. Maybe we're looking at some sensory, right? Some primary senses here that just haven't developed right. Or maybe there's some trauma, or maybe there's some visual perceptual, or maybe there is ADHD with some of this other stuff thrown in, right? But if we aren't treating the root of what is being a problem for this child and we're just trying to address the symptoms, then, that barrier is still going to be there for that child.
Yeah, so I hearing you speak about all of this, and I'm just hearing all these opportunities where we can help these moms.
Mhm.
Where we talk about occupation-based practice on here all the time. We had
Right.
Wendy Staub on here, kind of start us off in episode 2. But now we're talking about co-occupation-based practice, as
Right.
well as thinking about the role of motherhood and mothering. And so, we know there's this concern with development when there's the mental illness with
Mhm.
the mother and or the father.
Mhm.
And so we know that intervention works. There's
Yeah.
research to support that. So how do we translate all this stuff from the research into practice so that therapists listening can say, okay, now I know what to do to help these moms?
Yeah, and that's really important part. So I really do think the biggest value of my research comes from the practice scholarship angle and how what I've learned put we can impact practice, right? So just as a little background, none of the children that were in my sample had any type of diagnosis at all.
Well, okay.
So they were all considered typically developing. The reason they were, and that was an exclusion for my research, but the reason they were in my study was because their mothers had endorsed perinatal mental illness. Okay.
Mhm.
So 11 were boys and 3 were girls, right? So it would be interesting to see if I had a larger, like a better 50-50 split. And only one child had ever had OT before. So this was new for all of them. So what I
Mhm.
found was that 92.9%, if we're being exact, so 93% of the children in my sample had atypical sensory integration, measured either by their scores on the sensory processing measure or on the SOCM or on both. Okay, one child out of those 14 fell in the typical range on all the sensory assessments. So we know from the literature that the average percentage of children who have no other diagnoses or no other developmental disorder have sensory processing challenges. It's about between 5 and 19%, right? Depending on what you read in the literature. But in my sample, these are all typically developing children, and it was 93%.
Mm.
So what does that tell us? It's not a big enough sample to make any huge, but just looking at that sample, this is something we need to be looking at, right? There's a link between maternal mental health, attachment fostering behaviors, those co-occupations, and then vestibular and proprioceptive sensory integration.
Mm. Yeah. And I mean, this is something you don't have to be an early intervention therapist to necessarily be addressing the things that you're talking about because you're going to see kids 5, 10 years later
Mhm.
and start to put the pieces together. I always call it forensically, like we're going back in time and we're saying, let me
Yeah.
connect the dots here, but it starts to make sense. And I
Right.
think it's important to consider those contexts in there as if you can't help the mom now because it's 5 to 10 years later, but you can now help the kid and understand, why this kiddo is struggling in certain occupations.
True. But don't underestimate the impact of asking a mom
Hmm.
about herself and her mental health, even if it was 5, 10 years ago. Because the responses I get are just very emotional, and often they thank me for letting them share their story. Oh, no one has ever asked because I mean, you'll hear this from a lot of mothers and a lot of women that when they're pregnant, everybody's very concerned about them, right? And they feel kind of like a queen. And, people are all concerned about their health and their well being. And then they have the baby, and everybody's concerned about the baby, and the mother kind of gets left in the dust, right? So, and that's a bit of an extreme, but, you will hear that. So, I think the mothers realizing that they are an important part of their child's story and that their experiences are important. That can be really huge and really helpful for, creating some of that therapeutic alliance as well, and having them feel that you are really considering the whole family when you're looking at the needs of this child.
Well, it makes me think now that you say that, if it's 5 years later or 10 years later, and they have some kind of self blame going
Yeah.
on, and wondering, does my kid have these,
Hmm.
ADHD like behaviors, or they're having a hard time in school? Is that my fault?
Hmm.
Because of some of the things that I experienced, and like you said, the bad mom label that you might give yourself, or even, I mean, quite honestly, we know people will do that to them. So I think it's huge opportunity for us to let them share that and start to educate so we can alleviate some of that self-blame.
Right. It is not their fault, right? They have no control. And, I'm not trying to be exclusive, focusing my research on mothers, right? Because I
Mhm.
understand that there are plenty, like fathers are parents, and we have families with two fathers, right? Or families. But if you're a woman and you give birth, those hormonal changes and how that affects your brain chemistry is something that you just can't replicate, right? So, um, but it is not their fault. It is how their body responded to pregnancy, right, and delivery. You have no more control over that than you do of any other, mental illness or even physical illness that you might develop, right?
Right. And I wonder 5 to 10 years out, did you have anybody who really didn't remember, or any kind of challenges with that, or were they able to really clearly tell you? Because that's an interesting piece of
Yeah.
it too.
Actually, when I did my study, that was one of the things that we had worried about because we used the sensory processing measure in the SOCM, which were only normed for children as young as 5, right? Or the SOCM was. You could have used the I forget what it's called, the WE-SPM or the SPM for
Oh, yeah.
younger kids.
Right.
But the SOCM was only normed up to 5, and I really wanted to get a performance measure in there, and I'll address that in a few minutes, I think. But um, that was one of the things we thought, will their memories fade? Will they not really remember what happened? But when I talked to these women, they remembered that period of time with excruciating detail. And the literature has more examples of this. Even 30 years later, I forget which study it was, but they interviewed a mom 30 years later, and she felt all that pain just come back. Having a child is an incredibly significant event in a woman's life. And so a lot of the things that happen then, even way down the road, you'd be surprised at right at the little things that women remember, little details. So no, that actually wasn't a problem. In fact, I had to hold a few hands of these moms as they were, crying and just sharing with me about what it felt like at that time, the pain that they had, the isolation and pain are the really two big things that come through, and just that dread that, "Is this gonna be my life from now on? How will I ever enjoy my life again?" And it just really gets to your heart, but no, no trouble remembering that 5 to 10 years later.
Yeah, and I think that speaks volumes, you know. So, you're getting this child in the clinic, let's say 5, 10 years later. What are some things to think about? I know you said you use the SPM or you use the SOCM. So you're using some sensory assessments, of course, on this child who's been referred to you for things that would lead you to use a sensory assessment.
Mhm.
Um, what are some other therapeutic applications that came out of your research?
So another thing, which was not really an intended result, but that we found was the difference between the parent scoring and the parent report and what I would observe using the performance measure. So um, we gave the parents the SPM to fill out, right, and rate their child's behaviors that would indicate sensory, like typical sensory development or maybe some atypical development. And then while they were filling out, the demographic form, they filled out a maternal mental health survey and they did the SPM. I had the child to myself and I had them on the mat and had them, trying to catch balls and balance on one leg and, balance with their eyes open and their eyes closed and all of those different tasks that the SOCM has that looks at how the child performs certain movements to rate their sensory development and focusing again on proprioceptive, vestibular, tactile, postural reflexes, things like that. And what I found was that the SOCM generally ranked the child's sensory function lower than the SPM. So in performance, the children were actually scoring lower, indicating that they had more challenges than the parents report on the SPM. And I mean, you have to, like the performance measure, that's just a snapshot in time. Like that's what I saw. And the parents, of course, have known this child for a lot longer. Interestingly, when they were talking about behaviors, talking about, oh, yeah, he's always got bruises and he never knows where he gets them from and things like that.
Right.
Their description of the child matched more what I saw in the SOCI than what I saw in the SPM. So we have to be careful as clinicians of just using parent report. I mean, the SP2, the SPM, and the other sensory measures, they are great and they give us lots of information. But if we're really going to be assessing sensory function, we have to see them move. Um,
Oh, yeah.
the best would be in like free play, like if we can get them in the clinic and just have them play and climb and run and jump, but using a performance measure as well, because if we're doing the parent report, we're really only getting half the story. And what I saw in my research was they didn't always align. And I realized that this can be hard in some challenges, some settings, right? Like, do we have the space, or if you're evaluating virtually, right? And does the clinic you work for have these multiple assessments? But I think as much as possible, we have to be careful about just relying on parent report. I mean, because this is sensory.
Right.
This is how their body moves, how their brain develops, how they're processing, information from the environment, and we
Yeah,
need to
the
see
environment match.
yeah,
Yeah,
we need
exactly.
to see that.
So we have these opportunities here. We have, um, you know, pregnancy related mental illness. We have
Mhm.
postnatal situations where the mom, has the new baby and there's mental illness situations. So I see all these opportunities for therapists to jump in. Of course, we might not be in some of these places where we have access. So I see all these
Right.
opportunities, but it's
Yeah.
challenging, right? Then we have access to kids 5 to 10 years down the line, and we want to go back and include the pregnancy and the experience of the mom. I think it's really important to add that in. I love how you did that, and really get that story and make sure that it's, you're understanding everything and there's some education so maybe they can release whatever guilt they're holding on to. But, so I'm thinking of all these different things. But I know that you also talk about resilience. I love the topic of resilience, and you talk about that with how this is a part of this whole puzzle with these mothers who are, any mom who
Mhm.
who have struggled, are struggling, and how does that fit into the puzzle here?
Yeah, we have to look kind of at that resilience piece as well, because we have to remember that just because a mother has a pregnancy-related mental illness, it does not mean there's going to be developmental
Mhm.
challenges with their child, right? It's not a cause and effect; it's a correlation. We see, right, higher incidence of it. So resilience can be based on a lot of different things. It can be based on level of education, intelligence, support systems, feeling of self-efficacy, you know, a lot of these different things. And so what we as OTs can do is kind of work on the aspects of resilience that we can contribute to, so most of the mothers in my study were actually very highly educated. Most had bachelor's and master's degrees. And few of them had support systems, but not all. So if we know that women are at risk, and that's the biggest thing, is understanding when these women are at risk, how we can work on those feelings of resilience, teaching parenting skills, teaching mothering skills, teaching them about all these things that are important, and doing those screens where we're finding out if they have risk factors for maternal mental health.
Mhm. Okay, so we're talking about maximum impact in the clinical, hospital, home health environment, wherever we're practicing at. What are your top 3 takeaways to impact practice?
Um, I would say that we have to make it a part of a routine to ask about mother's mental health. That has to just be part of our regular assessment, and listen to these women. Don't try to use your own experience to interpret their stories, but listen to understand. Validate their feelings of isolation and pain and their hesitation to reach out. So really be a beacon for them. You might be the only person who's asking. You might be the only person they're willing to share their story with. So that's the biggest one. I think following up that, it's not gonna be really helpful if they tell you all this and you're like, "Wow, okay." So equip yourself with knowledge about local resources for women who are struggling with their mental health, especially pregnancy-related mental health. And remember, this is really important too, that pregnancy-related mental health can occur anytime in that first year after the baby's born. So some mothers struggle within the first few weeks, others will be doing great until the 7 month, and then they just get slammed with these symptoms. So don't think that once they're farther along in that first year, that it's not going to happen. Okay. And then I think the third thing is supporting mothers to engage in quality attachment fostering behaviors, right? During those co-occupations with their child, it's key. So support them in these interactions. Explain the importance of them being present and accessible to their child. Explain the importance of all of those non tangible, non concrete things, right? All of the touching and the rocking and the affection, and how that actually makes an impact on a child later on.
Well, I think really explaining the sensory rich qualities of the co-occupations and adding that to this is what can be brought in. I would imagine those sensory elements are going to help someone who's dealing with some mental illness challenges as well.
Right, right. Because don't forget, mental health affects your sensory integration, definitely your sensory processing. Right? So women who have anxiety or depression, what we're generally going to see are lower sensory seeking behaviors and higher sensory avoiding behaviors, sensory sensitivity, and more behaviors associated with low registration. So we have to understand that the mom might be dealing with some changes in her sensory tolerance as well, and can find ways to help support her with that.
Mhm. Yeah, these are all great um, suggestions that we can easily incorporate, which I love. And I think I love your first point about, we need to hear the story. And it doesn't matter if it's something that's happening right now or it's something that happened 10 years
Right.
ago. And I love that part. And I think, but having those resources, you're right. You don't want to hear the story and not have the resources available. And then we're great at teaching, what to do, how to do, connecting to resources. These are all doable things that you can put into practice, and then kind of just understanding all these contextual factors that I think are so important. So I know that you have some really great cases, and I want to make sure that we have those available in the resources that you provide for listeners who then do this for continuing education. And I think that would be another important thing for them to look at. But as we wrap up now, what I would like to hear are some kind of what's on the next frontier of this topic, moving forward.
Um, well, I have some ideas. Um, and I'm hoping to really get some of that qualitative research out, right? I have some things in the works where I'm talking with mothers, we're talking about their stories, and I think it's important to get that out because I think that adds, like, I can give you all of these statistics and talk to you
Uh-huh.
about what's going on and what's going to happen with the child. But when we can actually read and understand about what that mother is feeling, I think it helps us to empathize and to really understand what she's going through. So for me, it's
Uh-huh.
some more qualitative research. But I think what we really have to do is, talk to the people who are seeing these moms. So talking to the pediatricians,
Uh-huh.
right? Because they're bringing their child they may neglect themselves, but they're bringing their child in for well child visits, right? Talking to midwives, talking to community health centers where some moms will bring their child in for weighing and ongoing child development. Anywhere that they're dealing with these postpartum women and also women who are just pregnant and providing that information to them. I think if more women knew that this was a possible risk, if they knew the risk factors, and if they could, make connections with people to help them if they do have challenges, I think that we could really make it a less uh, have less occupational disruption and
Mhm.
and help them have a smoother transition to that occupation of mothering.
Yeah, and I love that idea of let's start educating other professionals. That shows them what we know, what we do, our
Mhm.
perspective. We can be leaders in this and work with pediatricians, work with OB/GYN, work with all of these different players. But like you said, I love how you just said it comes down to empathy, kindness, and non-judgment.
Yeah.
And I think that's the big takeaway from what you've been really telling us today. So this is really, I think, an important topic and this first step into really thinking about this from a bigger perspective. So thank you so much.
Thanks for having me, Nicole.
Yes. So that's all that we have time for today. Thanks again to Dr. Teddie Buchner for the insight and practice related takeaways that we have on the topic of pregnancy related maternal mental health.
Thank you for tuning into this episode of Pediatric Pioneers by MedBridge. Please be sure to subscribe and listen to more of our episodes on Spotify or on your favorite podcast platform and at medbridge.com. If you're listening outside of the MedBridge catalog and would like to access the bonus resources and receive continuing education credit, simply log into your MedBridge account and complete the quiz for this episode. Pediatric Pioneers also listens to you. If there is a particular practitioner that you'd like to hear from, or if you have a question or challenge that you'd like to explore on this podcast, please let us know by leaving a comment on our Instagram posts or by emailing podcast@medbridge.com.